In this module, I am going to talk to you about pneumothoraces, basically the diagnosis and management of pneumothorax, but I am going to go into a little bit more of detail even about the pathology and pathogenesis. So, we will start off with basics, things that you know about already. So, you know pneumothorax is presence of air in the pleural space. Now, the negative intrapleural pressure ensures that there is no spontaneous migration of air into the pleural cavity, because the pleural cavity has a negative pressure of 36 millimeters of water. Hence, when you think about it, there can be three possible mechanisms by which air can leak into the pleural cavity. First, if there is a communication between the alveolar and the pleural space. Second, if there is air coming in from outside, so if you have a communication between the atmosphere and the pleural space. And third, which is more a theoretical and a very rare possibility, is when this presence of gas producing organisms in the pleural space. So, those are the theoretical possibilities by which you can have air in the pleural cavity. When you think about primary spontaneous pneumothorax, I am going to tell you something which is slightly different to what the long-standing ideas have been. So, primary spontaneous pneumothorax conventionally is thought to be absence of clinically apparent lung disease over which you get a pneumothorax. Secondary pneumothorax conventionally is when there is underlying lung disease in the way of COPD, cystic fibrosis, pulmonary fibrosis, lung cancer, and you can think of a wide variety of other lung diseases. And then conventionally, you have a third variety which is non-spontaneous pneumothorax, which is caused by trauma and can be iatrogenic, so caused by us. I start off by showing you this X-ray. So, we start off with this particular case where you look at a man 18 years old who is a non-smoker who comes to you with sudden onset chest pain. And if you look carefully, and I don't know how well this projects to you on your laptop or the computer that you're watching it on, there is a chink of pneumothorax at the very lung apex. And you can see this is inspiratory and expiratory film, and you can see it in both the films. Maybe in the second one, it shows up better. So, this is the scenario in which you think about aspirating air. And when you think about aspirating air, you think about the area which is thought to be the safe area for aspirating air. And you can see that 2 centimeter area over the anterior chest wall, but not completely medial. You're going laterally to avoid the great vessels, which would be the safe area for aspirating air. So, for the first episode of pneumothorax, the treatment should be based on symptoms rather than the size of the pneumothorax. So, there is in patients who present for the first time a role of conservative treatment, and there have been randomized controlled trial, and later on in my talk I will show you of much of this evidence where avoiding a chest tube at the first go with a patient who has no underlying lung disease and never had a pneumothorax in the past is actually evidence based. It's based on randomized controlled trial. So, one is conservative. Second, if you're going to intervene, the question arises, how do you go about intervening? So, do you go for aspiration or do you put in a chest tube? And I have summarized here some of the evidence that's available. So, the success rate is not very different. So, you're looking at a success rate of about 60%, give or take 2 to 4%. The success rate after 1 week again is very similar. So, you're looking at a ballpark of about 90% with either technique, be it aspiration or be it a chest tube. What's different, however, is hospitalization. So, you can see that when you're aspirating, you send the patient home the same day. You do a repeat chest X-ray, you show that the lung is expanded, and off the patient goes home. So, 52% of patients require to be hospitalized, whereas 48% can go home. Obviously, if you're putting a drain in, 100% of your patients end up staying in hospital. Cost effectiveness is not something that's been addressed, but I guess it's common sense that if you're sending a patient home without admission, you're saving a lot of money. And even I think common sense tells you don't need evidence for this. Common sense tells you that aspirating is a far safer technique as opposed to putting a chest tube in. So how common is this disease process? We're going back a step. We have talked a little bit about the evidence regarding treatment. I take you back and I talk a little bit about epidemiology. So we are talking about a disease process which is not rare by any standards. So when you're looking at the male incidence, the incidence is about 7.4 to 18. There's been small trials in India which has looked at epidemiology, very localized city-based trials which have looked at epidemiology, and it's consistent with what shows up on that slide. So about 10 per 100,000 in case of men and about a third of that in case of women. So in women, you're looking at a ballpark figure of about 4 per 100,000. In men, you're looking at about 10 per 100,000. The risk factors, again, you know about. So you know about the so-called Marfanoid habitus. We say ectomorphous habitus there, but you know about this tall, gangly chap with a very long arm circumference. You know about the high arched palate. You know about hyperlaxity of joints. So that's the ectomorphic habitus with whom you associate a primary spontaneous pneumothorax. You've seen from the incidence that men are more liable to getting a pneumothorax as compared to women. Smoking, especially smoking cannabis, seems to increase your risk significantly. If you think about the entire plethora, the entire basket of interstitial lung disease, RBILD seems to have a greater incidence of causing pneumothoraces as compared to the other interstitial lung disease. And then, maybe in lines with the Marfanoid habitus, there seems to be a genetic predilection, there seems to be an embryogenic predilection as far as causation of primary spontaneous pneumothorax is concerned. What about other precipitating factors? And again, these are anecdotal reports. There have been no trials, but these are case reports. These are things which have come up again and again when people have reported their incidence of pneumothoraces. So the atmospheric pressure is important. A sudden change of about 10 millibars leads to a clustering of primary spontaneous pneumothorax. And here, even though these are anecdotal case reports, we've actually got a lot of case reports. So a sudden change, 10 millimeters of mercury, leads to a clustering of pneumothoraces in a particular regional geography as far as the incidence is concerned. Storms or abrupt temperature changes seem to do the same. So you seem to have a sudden increase in the incidence of pneumothoraces in an area when there are storms. This has been reported from the US. You know about the storms, they go by various acronyms, and there seems to be an increased incidence of pneumothoraces in that population. Same with loud music. Here the reports are anecdotal, but young men, Marfanoid habitus, loud music seem to go together and add up in increasing the incidence of pneumothoraces in this population. Other risk factors which are even more anecdotal, hence less evidence, physical exercise, so lifting heavy weights for instance, a forced Valsalva maneuver, all of these also seem to increase the risk of pneumothoraces to an extent. So that's a little bit about epidemiology, it's a little bit about risk factors. One of the things that I think I started off with, and I'd repeat again, is that often we end up doing an inspiratory and an expiratory film in patients with pneumothoraces. However, this again is not evidence-based. There's no evidence that adding in a routine expiratory film actually increases the diagnosis rate of patients with pneumothorax. Contralateral shift of the trachea and mediastinum is a normal phenomenon in all patients with pneumothoraces, spontaneous pneumothoraces, secondary pneumothoraces, and it does not, and I repeat again, it does not actually indicate that someone is having a tension pneumothorax. And as you see on that slide, it is not usual, it's very uncommon for a patient with a primary spontaneous pneumothorax to end up with a tension pneumothorax. And like I said, I was going to discuss a little bit more about terminology. I think it's about time when we start discriminating between primary spontaneous pneumothoraces and a secondary pneumothorax as far as the treatment algorithm is concerned. So primary spontaneous pneumothorax, you have to act. but you can think and act. You can pick out what exactly you think is the best mode of treatment, and you can spend some time doing it. Secondary pneumothorax does not give you that chance. There you have to act fast and act immediately, because otherwise it costs lives. So go back to my 18-year-old gentleman who is a never smoker. He comes back 2 months later, so we aspirate. You remember the triangle of safety I showed you a little while ago. So we had aspirated, the lung had come up nicely, but lo and behold, 2 months down the line, he comes back again with a similar pneumothorax. And you can see on the second chest X-ray on there that there's a nicely positioned apical drain which has now drained the pneumothorax and the lung is expanded again. So going back to possible evidences of reasons for mechanism. The problem is that this is not evidence-based. This is more based on lung physiology and our understanding of what sort of mechanism might cause a pneumothorax. So going back to the three mechanisms, we start off with the one which seems the most promising, the one which is probably the causation of most pneumothoraces. So communication between alveolar space and the pleural space. You see this in patients with emphysema, where there are apical blebs, where there are small cysts, all of which are liable to leak, rupture and result in escape of air into the pleural space. Now there's a popular misconception, and we'll come back to this again, but there's a popular misconception that this air leaks only from one bleb or one cyst. That is indeed not the case. We have seen, and this is again physiological studies rather than being evidence-based, that the leakage from the pleural surface is more diffuse. So patients with primary spontaneous pneumothorax seem to have an increased pleural porosity, which results in air leaking from the alveoli into the lung spaces. And you can see that on the slides on there. So you can see in the second set of photographs that there's an apical rim of air all around the right lung, and also an impression of a similar air leak around the left lung. So this cannot be the result of leakage from one bleb. This is the resultant leakage of increased pleural porosity from throughout. So this is the definition. This is how they've defined. This is from years ago. This is from about 30 years ago now, where they have defined what they mean by pleural porosity. And just to take you through the definition, it says disrupted mesothelial cells in the visceral pleura, which is replaced by an inflammatory elastofiber layer with increased porosity, which allows air leak into the pleural space. So what's the indirect evidence for what we are saying? The fact that blebs and bullae occur in about 15% of asymptomatic so-called normal patients. If you do a bullectomy, the pneumothorax recurs, and it's not a small number, it's up to 20% of patients where this pneumothorax recurs. So there has to be more than one source of air leakage, because otherwise the bullectomy should have sorted the problem out. Electron microscopy shows that the mesothelial cells and pore-like structures are covering the alveolar membrane, and the same shows up on fluoro-enhanced autofluorescence or on infrared thoracoscopy. So when we talk about the pathogenesis of a pneumothorax and think about treatment modalities, we think about at presentation, like it was in the initial presentation of the 18-year-old boy, and we think about how to prevent recurrences. And I think over the course of my talk now, I'm going to tell you about certain thought processes, things that we used to think which are anecdotal but are really not true, and I will try and abolish these misconceptions. So with the advent of thoracoscopies, pictures like this have become very common, and you can see on that picture the bleb on the apical pleura, and you would see similar blebs elsewhere. So you don't need a rocket scientist to say that this is a bleb which is likely to leak, which is likely to rupture, and unless you do something about pleural porosity here, it is likely that a pneumothorax will recur even if you did a bullectomy here. So the agent with which you prevent a recurrence, in most cases, at least in my practice and most practices I know of, would be graded talc. And you see the European costs there, but even in our country, it's relatively cheap and cheerful. We know it's safe. More importantly, we know it's efficient. And in patients with pneumothoraces, this is by far the most efficient agent that we have. There was a lot of thinking about ARDS, the risk of ARDS in these patients if they are given talc. However, large prospective randomized controlled trials have shown that they're extremely few and far between. So you can see one case out of 660, and even there, the patient recovered. So it's safe, it's efficient, it's cheap. What else would you want from an agent which you're putting in to prevent the occurrence of a pneumothorax? So that's the concept about young men and primary pneumothoraxes and about secondary pneumothoraces. Next, I talk about a different group, maybe a different breed of illness, even though we continue to speak about pneumothorax. So we talk about young girls. So here I show you a 43-year-old female who's a non-smoker, who a lot of years ago, about 15 years ago, had bilateral pneumothoraces. She was treated with talc, bilateral pleurectomy thereafter, but she presented 6 years down the line with chronic dyspnea. And you can see the chest CT scans there, and you can see the recurrence of a right apical pneumothorax. You can see loculate pneumothorax around the right middle lobe, and you can see a similar picture in the right lower lobe. The reason the entire lung is not collapsed is simply because you had made an effort to prevent a recurrence at an earlier date, first with talc and then with pleurectomy. But in spite of the lung being stuck at places, you see that there's a substantial collapse of the lung on the cuts that are shown to you. So the reason for these pneumothoraces in this lady is there for you to see. So you see the pleural surface there, and you see the vascularity, the engorged blood vessels over the pleural surface. And this is a lady who is having her periods at the time when she had a pneumothorax. So the disease that we are talking about here is catamenial pneumothorax. So this, as we said, occurs during menstruation, occurs during periods, it's spontaneous, it's recurrent, it occurs in women of the reproductive age, and like we said, in most cases would occur when she's having her periods. Most ladies would have this associated with thoracic and pelvic endometriosis. And you can see that's a vast majority of patients, about 90% of patients. They've been given various nomenclatures. You can see one of them there. It's called thoracic endometriosis syndrome. And you can see these patients present with chest pain related to the pneumothorax. They can have hemoptysis, hemothorax. If you do a thoracoscopy in these patients, you would see lung nodules, and there is chest pain during periods. However, it's not all a straight temporal relationship between them having periods and having a pneumothorax. It can be 72 hours after the onset of periods, or it can be within 5 to 7 days of them having their periods. In ovulating women, pregnancy, menarche, and ovulatory suppressants are generally not considered. However, there are certain case reports that women on ovulatory suppression and during pregnancy very rarely have pneumothoraces, but the incidence comes down significantly. Very rarely again, not very rarely, maybe about 25% of cases, pneumothorax might happen in postmenopausal women, but they too are found to have endometriosis, and this endometriosis would have started prior to them having their periods. So this is the lady I was talking about a little while ago. You can see a significant pneumothorax on the right apex with the drain in situ, which is being drained, and you can see on the subsequent CT scans that the lung has come up again. I'll skip that and finish off the various age groups and the ones where we worry about pneumothoraces, talking about the most worrisome group. So I talk about old men here, and when we talk about old men, we talk about people who have underlying interstitial lung disease or any other form of underlying lung disease like COPD, for instance. So you see this gentleman who has a small pneumothorax by comparison. You can see it in the region of the right base. The second X-ray shows you partial re-expansion with a small area of pneumothorax at the right base again. And when you see this on the CT, you can appreciate the pneumothorax better, but what you also see is a small area of surgical emphysema. So these are patients, and I'll go back to the previous slide, these are patients you worry about. You worry about these patients because they can decompensate early, they have tension pneumothoraces, they become hypoxic and desaturate early on, and these are patients where it's essential to drain the pneumothorax essentially with a chest drain as soon as possible. So in conclusion, for this part, we say that primary spontaneous pneumothorax is not a medical emergency. Spend some time thinking between the three options available to you, namely waiting and watching, so conservative treatment. Second, putting in a needle and aspirating and sending the patient home. And third, maybe in a small minority of patients, you would have to put in a chest drain of some description. There's a lot that you can do as a pulmonologist, and in most cases, almost in all cases, you would not have to involve your friendly cardiothoracic surgeon. However, when you see an old man and a young lady, think about the two conditions I have described. So think about catamenial pneumothorax. It's not as uncommon, as rare as you think if you look for it actively, especially in today's day and age where thoracoscopy is more easily available. And think about old men with underlying COPD, interstitial lung disease, etc., because they are the people where quick management, early drainage is indicated, and that might end up saving lives. A lot of what I have talked about till now is based on this ERS task force statement, and a lot of the slides are also borrowed from there. So I will go ahead and I will spend the next 10 minutes talking about this statement in particular. I think this is relevant because it gives you clinical clues as to how to diagnose and treat patients with primary spontaneous pneumothorax. So this task force is mainly European, so 8 European countries, and it was a combination of pulmonologists and surgeons who did an extensive systematic literature search and then set up a task force which looked at 5 key areas. They looked at epidemiology, diagnosis, classification, treatment of first episode, and treatment of recurrent or complicated primary spontaneous pneumothorax. I will talk about certain aspects I have talked about already, but I think that's worthwhile because it re-emphasizes what I have said before. So they talked in detail about pleural porosity, which we have talked about before, and they came up with this simple algorithm about air leak into the lung and the interstitium, then into the hilum, then pneumomediastinum, then a rupture of the mediastinal parietal pleura causing a pneumothorax. They too felt that a one airway, one bleb, one leak concept is oversimplistic. They emphasize something I have told you already, the fact that primary spontaneous pneumothorax and secondary pneumothorax, the distinction is gradually becoming blurred. And the reason it's becoming blurred is because more and more patients are ending up having CT scans done. So when you do a CT, you find a bleb, you find a few lung cysts, you find evidence that there might be increased pleural porosity. So do you think this is primary? Do you think that's secondary? And that's an open question, which is why the overlap between the two has increased and the lines between the two have gradually become blurred. So like we said before, do we think we are moving towards a new classification? So recurrent pneumothorax is an episode which occurs on the same side of a prior pneumothorax, or if you have a contralateral pneumothorax. So in the new classification of pneumothoraces, there are these different types, and we've actually talked about most of these before. So iatrogenic is probably the best. In that, the lung comes up easily, it's a benign course, and small pneumothoraces, maybe a conservative approach is all that's needed. In traumatic, it's actually the trauma and the parenchymal injury which results in the pneumothorax, and again, unless there's been a lot of lung contusion, the lung comes up easily in most cases. We have spoken at some length about catamenial pneumothorax. The problem here is the high risk of recurrence, and you saw that in the case that I showed you a little while ago. Then there are people who have genetic predisposition. We spoke about the ectomorphous habitus, And to highlight this point, you've got two diseases there, Marfan syndrome and Birt-Hogg-Dubs syndrome, which multisystem pathology, which seems to lead more to spontaneous pneumothoraces. Then you've got idiopathic pneumothorax, which is again got a low risk of recurrence and conservative treatment or just aspiration. So ambulatory treatment might be appropriate in these patients. Then you have the variety which is picked up on a CT scan incidentally. So patients with abnormal parenchyma, which is previously unrecognized. And if you remember, I spoke about respiratory bronchiolitis interstitial lung disease and bullous lung disease, where this might occur. And here, early surgical intervention to prevent recurrence is important, and I cannot highlight how important it is to stress upon smoking cessation in this group of patients. It might happen in patients who have evidence of immunocompromise, patients who've got infections like PCJ, so pneumocystis carinii Jirovecii infections and so on. And here obviously treatment of the pneumothorax, but equally identification of the immunocompromise and targeted antimicrobial treatment is very, very important. And then you've got the last group, the one I called old guys. So obviously it's not just guys, but the group where there's underlying secondary lung disease. So COPD, interstitial lung disease, cystic fibrosis, lung cancer, you know this list as well as I do. And here lies the risk of mortality, here lies the risk of ongoing leak and recurrence, and here lies the group where you might want to refer to your friendly cardiothoracic surgeon at an early date for optimizing management of this condition. So with primary spontaneous pneumothorax, evacuation of air is the goal like any other condition. However, this is only if it's necessary. And here we have two concepts. We have the British concept, which is with the BTS guidelines, which is size and symptom driven, size being given the priority. And then the American College of Chest Physicians from a few years ago, which has a more aggressive approach, which says it should be promptly treated with objective and complete re-expansion of the lung, if required, with putting a chest tube in. And it should be done, so a chest tube should be put in with any pneumothorax which is more than 20% in size and irrespective of symptoms. In prevention of recurrence, you discuss the various groups, and I'm going to do that in a minute. So this is the size-driven approach. This is the Lights Index, and you can see the calculation on there. Unfortunately, even though this is effective, it does not accurately estimate the size of the pneumothorax. So in the size-driven approach, the problem is, what do you define as being large? And you can see there's a discrepancy between the American College of Chest Physician guidance and the BTS guidance. The BTS calls anything more than 2 centimeters as being large, whereas the ACCP calls anything more than 3 centimeters as being large. So that's how the BTS looks at it. So you can see that at its maximum diameter, you do a perpendicular onto the chest wall, and if it's 2 centimeters or greater, then intervention is required. So I find this algorithm simple, which is why I'm showing it to you. So this is the BTS Pleural Disease Guideline of 2010, which talks about the management of spontaneous pneumothorax. If the patient has bilateral pneumothorax, or if the patient has any evidence of hemodynamic compromise, then drainage is the only answer. So you proceed and put a chest drain in. In all other patients, you consider the circumstances. So if your patient is aged more than 50, if he has a significant smoking history, and if there's evidence of underlying lung disease on examination or X-ray, then you would think about putting a drain in. If your answer to these questions is a no, and you infer that the patient has a primary spontaneous pneumothorax, you determine the size of the pneumothorax. If it's more than 2 centimeters in size and the patient is breathless, then you put a needle in, you aspirate, and if the aspiration is less than 2.5 liters, it's likely that the lung has expanded with your maneuver, and you repeat a chest X-ray and you ensure lung expansion. However, if the size is less than 2 centimeters in size, you consider discharging this patient and reviewing the patient in the OPD in about 10 to 14 days. I know it says 2 to 4 weeks, but I think 10 to 14 days would what I would do in my practice. You bring the patient back, you review the patient with a repeat chest X-ray. If your patient has been aspirated and feels better with it, the lung seems to have expanded, you would still bring the patient back. If the lung is not expanded with your aspiration, the lung is still collapsed, obviously your patient ends up needing a chest drain. So if you think about spontaneous pneumothorax, and going back to the previous history, I spoke about this. So if you had the criteria we talked about, if you were aged more than 50 years, if you had a smoking history, and if you had an underlying lung disease on chest X-ray, then actually you have a secondary pneumothorax. And here drainage becomes of paramount importance. So if it's more than 2 centimeters in size, you go for a chest drain. If it's less than 2 centimeters, so size is 1 to 2 centimeters in size, then you aspirate. And if you are successful, then that's fine. If you're unsuccessful, then you would put in a chest drain at that point of time. Other than a small minority of patients where the lung expands with aspiration, most of your patients with a secondary pneumothorax would actually get admitted to hospital. And my recommendation is that these patients, irrespective, should be admitted in hospital for 24 hours to ensure that the lung has come up and stays up, and you should repeat a chest X-ray at that point of time. So that's the entire guideline in summary, and I think that algorithm is something that you can keep in mind because it's simple and easy to replicate in clinical practice. The ERS, so we have spoken about the BTS, we have spoken about the ACCP briefly, and I personally feel the ACCP attitude is a bit too aggressive, at least about pneumothoraces. Let's look at the ERS approach. The ERS actually takes even a softer approach. It's a symptom-driven approach. So the decision to evacuate air from the pleural space is usually determined A, by the patient's wishes, and B, by the patient's symptoms, C, by their ability to carry out their activities of daily living, and last, by the size of the pneumothorax. So you see the paradigm shift. We are not talking about management of size of a pneumothorax here. We are talking about management of symptoms of a pneumothorax and hence managing the wishes of the patient. So for a symptom-driven approach, you're striving for lung re-expansion, large drains plus apical placement of tubes plus suctions equals to the standard approach passed on from one generation to the other. This is not symptom-driven. What I spoke about earlier was symptom-driven. This is what we have spoken about, how we have managed pneumothoraces for years together. It brings up two important points. The first question to answer, which seems common sense driven, is does bringing the visceral and the parietal pleura together, does that facilitate spontaneous pleurodesis? And if it does that actually end up resulting in healing of air leak in these patients? So this symptom-driven approach divides the patients into 4 different groups. In group A, you are managing these patients conservatively. So a practice originally suggested by experience with artificial pneumothorax, the understanding is that if artificial pneumothoraces did not cause a lot of respiratory embarrassment, why would a small pneumothorax do that? So this is practice-driven experience based on artificial pneumothoraces, and you're doing a conservative management. These patients remained at work, except if the work involved physical labor. You wouldn't let them work in that case. Then you've got group B, C, and D. Group B is simple aspiration, group C is chest tube drainage, and group D are patients in whom they would end up having a pleurodesis. And you see the different groups on that particular chart, which I'm not going to read out for you. If you look at the symptom-driven approach, group A is entirely conservative, and the results that you get here depends on the duration of lung collapse. So as you can see, if the number of days of collapse is greater, then your chances of lung coming up is lesser. Equally, you find that if the patients have underlying emphysema, the chances of the lung coming up in these patients is also going to be lesser. So 2 driving factors there. How long has the lung been collapsed before you diagnose the pneumothorax? And second, you're looking for underlying lung disease, emphysema in that case, in which case it makes it a secondary pneumothorax, and hence spontaneous re-expansion of the lung is going to be unlikely in these patients. So let's look at the most important thing. So the lung comes up, but what is the likelihood that there's going to be a relapse in these patients who have been treated conservatively? And you can see the relapse rate, they're not very impressive numbers. However, you do see a sudden increase between the third and fourth year. However, the numbers that you can see is low. So this is a practical approach. This can be an approach which is worth emulating. The other thing which has come up again from lots of years ago, Stradling and Poole in thorax, from one of the earliest issues of thorax, the hypothesis that visceral leak sites are more likely to heal if the lung remains collapsed. Now this is a physiological comment. We will never be able to substantiate this, but this is a thinking. The fact that if you heal a visceral pleural leak, the lung might actually remain collapsed in these cases. So there was this big trial, the Australasian trial, and the X-ray is actually from this particular trial, which is the do-nothing approach. So this is conservative treatment in all patients irrespective of the size of their pneumothorax. The aim of this study was to determine whether conservative management of primary spontaneous pneumothorax was an acceptable and safe option. And the two arms here was, one was intervention and the other was doing nothing. The primary outcome was the proportion of participants with complete lung re-expansion after 8 weeks. And you can see the actual group and the target group on that particular slide. If you look at the results of evacuation of air using a needle or a tube, and if you look at the various studies which have compared this, you can see that in most the results are non-significant. So there's not much to choose between whether you put in a needle and aspirate or whether you put in a tube in these patients. The difference, if any, comes in the number of hospital stay days, which again is something we spoke about earlier. But as far as success rate is concerned, there's hardly a study other than the Nopen study. Nopen study is also admissions, so there's hardly any study, but the success rate is different. Which one to use? And again, we have spoken about this. We have said needle aspiration is effective in patients who have got a relatively small pneumothorax and the patient can be discharged. There is a small but significant failure rate, but if there is failure, then the next step would be to put in a chest drain. The other attitude which is shown on there is to put in a small bore tube. And you can see an illustration of one of these small bore tubes with a Heimlich valve attached to the end. So this can be more long-term. It's non-intrusive, it's comfortable for the patient, they can go to work with this. The only little thing that you need to worry about is preventing infections in these patients. The other question that I'm often asked is the size of the tube. Should it be a small bore tube or should it be a large bore tube? And again, the literature is rife, small versus large, both are equally effective. And I don't think we need to go into a more detailed discussion. What about suction versus no suction? So if you have to have suction, suction is required only in a small minority of patients. You can see the data on there, 70% of patients, lung expansion by day 3 without suction. Hence, there is no role of suction in most of your cases, definitely not in all your cases. However, the question remains, the question I asked before, does actual apposition of the two layers of pleura, the visceral and the parietal pleura, does that actually translate into prevention of recurrence? Apposition does not induce pleurodesis, and hence the theory that just opposing the two layers of the pleura by doing negative suction probably is not substantiated by evidence. What about the prevention of recurrence in the first episode? Again, this is something which is hotly debated, and you can see the various studies across the years. So you can see studies between 1966 to 2013 which have looked at recurrence rates after the first episode. There is this Taiwan open label trial which spanned 2 hospitals, 214 patients with after the first episode of primary spontaneous pneumothorax. So pigtail catheter was used as control in one arm versus pigtail catheter plus putting in a pleurodesing agent, which happened to be minocycline in these cases. And after 1 year of follow-up period, when you looked at recurrent pneumothoraces, they found that the rate of pneumothorax in the arm which just had the pigtail without minocycline was significantly greater as compared to the group where you did pleurodesis. This is one trial which sort of recommends pleurodesing patients early and hence reducing the incidence of pneumothoraces. The usefulness of CT in predicting recurrence of primary spontaneous pneumothorax again is not something that has been established, and hence screening with CTs is not useful. So I think these are questions that are still unanswered. We don't know the true incidence of primary spontaneous pneumothorax. We are unable to identify subgroups of high-risk recurrence of primary spontaneous pneumothorax which warrant an intervention, which warrant treatment after the first episode. And we do not know whether all patients with primary spontaneous pneumothorax should either be treated by a conservative or by ambulatory care. What we do know, however, is that in these three groups, the ones in yellow, so patients with genetic predisposition, patients who've got endometriosis, and patients who've got abnormal lung parenchyma due to underlying lung disease are groups where intruding early, where stepping in early and putting in a chest drain is actually going to help, and pleurodesing these patients early would also actually help. Prevention of recurrence in the second episodes, the indications for definitive management, and these are again things we have talked about. So episode of primary spontaneous pneumothorax, second episode, hemopneumothorax, bilateral pneumothorax, professions which are at a risk, and I'll show you some pictures in a minute, and persisting air leak for more than 3 to 5 days. However, again, these are mostly anecdotal and the level of evidence for these is not very high. So the last question I try and answer is how to cope with prolonged air leak. So if the air leak has persisted with failure of lung expansion, early intervention would be in 3 to 5 days. Alternatively, you could put in a one-way Heimlich valve like I showed you, and you could wait for longer for the lung to expand in these cases. And I think individualization is important. There is no head-to-head trial comparing these two approaches, and individualized approach maybe in consultation with your surgeon is what you would want to do. How would you predict prolonged air leak? And there are places, there are centers which have looked at digital measurements, but I don't think they are clinically relevant. So I finish off with these management conclusions. So management of primary spontaneous pneumothorax, first episode should be symptom driven, and we should mainly highlight on aspirating these patients rather than putting in chest drain. Recurrence prevention and definitive management is pleurodesis, and these are the indications that we talked about for pleurodesing patients early on in the treatment. Talc poudarage with graded talc is safe and is the most cost-effective approach, and I have shown you some evidence about this. Surgical approaches early, especially in the groups we talked about. Remember the young ladies and the old guys, VATS is preferred to open thoracotomy in these patients. The other surgical approaches, so things like routine excision of apical bulla, selective excision of bulli or blebs, bullectomy and so on and so forth are at best controversial. The newer techniques like putting in endobronchial valves or electro and cold coagulation of blebs and bulli are still evolving, and again the data is not substantial. Something we do poorly is controlling pain as a complication of pleurodesis. This is simple but often not thought of, and again the ERS statement emphasizes that pain control after pleurodesis is an important thing. So take home messages: evacuate air in patients with symptomatic pneumothoraces. Don't go by size, go by symptoms. Forget the large size tubes, your small size tubes will work as well, and a case to the point is putting a pigtail catheter along with a Heimlich valve at the end and sending the patients home. Start with manual approach, and your area of safety is the lateral part of the anterior chest wall in the quadrangle that is shown on there. A water seal drain with a portable Heimlich valve is what is important. Putting suction in these patients across the board is not the carry home message. Suction can be applied, but in a minority of patients. In patients with a persisting air leak after day 4, pleurodesing these patients with talc would be something that I would strongly recommend, and the ERS does the same. And prevention of recurrence should be discussed on an individual basis. People who are pilots, people who work in high-risk professions like diving, etc., would have pleurodesis done, at an earlier date. So these are the concluding remarks. Smoking cessation advice for each patient who is a smoker with primary spontaneous pneumothorax. Symptom-driven approach, like we said, aspiration being important, definitive treatment in groups that we talked about. Pleurodesis can be mechanical, pleurodesis can be chemical, but talc pleurodesis is what we recommend, and that would be by Pudderaj with thoracoscopy. This is safe and very effective. Incidence of primary spontaneous pneumothorax and its recurrence rate in some groups we have talked about without much of evidence. We don't really have evidence about genetic testing, but that is something for the future that we need to think about. And the role of surgical lung resection and bulectomy is very controversial and probably questionable over a period of time. So I have told you a lot of things. A lot of things are anecdotal, like I said. We don't have evidence. So this is work in progress. And I know that the European Respiratory Society is thinking again about redefining primary spontaneous pneumothorax or spontaneous pneumothorax generally. And maybe when I do this talk in a year's time, I will have a different data set to talk to you all about. Thank you very much for listening.